It's time to revise. Let's smash paper 3. We're going to do schizophrenia today. We're going to do the interactionist approach to schizophrenia. And don't forget, that covers the interactionist as an explanation, but also what do we mean by interactionist treatments, okay? Let's do it. There's some exam style questions. Here's your chance, as always, to pause the video and do something active with it, whether that's trying them under time conditions, whether it's planning them, whether it's talking them through with someone, up to you. But give it a go. Come back when you're ready to hear my thoughts. Okay, right. Explain the diathesis-stress model of schizophrenia. So this could be a specific question because it's named on the spec and it's been a question before. I think it was a multiple choice when it came up. But the diathesis-stress model is basically the idea that schizophrenia is caused by or is the result of an interaction between a pre-existing kind of predisposition, I suppose, which might be biological, and a stressor or a trigger, which might be environmental. Okay? All right, done. Outline the interactionist approach to treating schizophrenia. So, interactionist treatment is where you're going to give the patient, two or more kind of different treatment modalities that are going to work together. Yeah, it's not just this is misconception. So let me talk about this. It's not just schizophrenia is diathesis-stress. So they've got a gene that's caused schizophrenia, and then there's stress in their life. So we're going to give them drugs to combat the gene and CBT to combat the stress. It's not really like that. Okay, it's more like this. Schizophrenia is caused by a complex interaction of biological and environmental factors, including psychological factors and the patient's own interpretation of their own environment and interactions with other people. So what we need to do is we're going to give them antipsychotic medication because that will help to clear their thinking and reduce some of their symptoms. And it's going to help them to engage with other forms of therapy that they might need, such as CBT. And when they're doing the CBT, we're going to be reinforcing and talking about, maybe the drug therapy, so that the CBT is going to help them to take the drugs, and the drugs are going to reinforce their thinking and help them to continue to engage with the CBT, and it's all going to work together like that. Okay? So it's all about interacting. Yeah? All right. Bit of application. Tom's parents recently got divorced, Tom struggled with it, and he's moved away to university. Sounds like Tom's having a tough time there. Okay. Family history of mental health conditions, uncle with schizophrenia, older sister with DID. Okay, fine. He's otherwise healthy, but recently we've had some hallucinations and delusions. Okay, so we're now experiencing symptoms of schizophrenia, and we need to explain what's going on there. Now, it doesn't actually say interactionist approach here, which is possibly they could have been more helpful. Well, I could have been more helpful, I wrote it. But what it's leading you towards is talking about, there's family history. So you see that, you think, okay, that's a predisposition, yeah? You see divorce and you see moving away to university, you see stress, you think predisposition, stress, trigger, that's diathesis-stress, okay? That's what you need to be thinking. So, 2 marks of knowledge, we're going to outline the diathesis-stress model or outline what interactionist means. And we're going to make some links, yeah, for 2 application marks. So the predisposition is the family history. The fact that he's got an uncle with schizophrenia suggests that there's this maybe genetic risk that's been inherited. Not sure I do much with the DID, to be honest, there. And the moving away to university and the recent parental divorce, that's put a lot of pressure on Tom. He's experiencing a lot of stress. That's triggered that predisposition, which is why he's experiencing symptoms. Okay, what we got next? Sonia. We met Sonia in a different video, didn't we? So this time we're listening to her mother talking about Sonia's experience. It was tough for her. There were some significant events when she was only 5 or 6. Events that must have left a mark. Now that sounds like some kind of childhood trauma to me. I didn't kind of be more kind of explicit than that because, we don't really want to do that for the purposes of, what's going to be written in an exam paper, but it sounds like there's maybe some childhood trauma there. Okay, so let's carry on. When she was 15, her dad, who's got schizophrenia too, he walked out. So again, that sounds like, there's some childhood trauma, but now when she's older, we've also got some other additional stressors going on. It was too much for him, okay? The doctors are helping, she's on medication, and maybe some therapy as well. Okay, right, so there's a lot to unpick here. But possibly the key point in terms of understanding the question is that even though it's an 8 marker, it's not an evaluate question. So this doesn't tend to come up very often. It did a few years back. It was a 4+4, knowledge and application. Yeah, so you need to know that that can happen. And that's why I'm going through it here, okay? So for 4 marks of knowledge of the interactionist approach, again, you're going to talk through the diathesis-stress model, you're going to talk about that predisposition, you're going to talk about that trigger and that kind of working together. You're going to talk about the treatment as well, though, because it just says the interactionist approach, and treatments are mentioned, so that will be important, okay? We'll come back to that in a second. So we've done knowledge of the explanation. Link it to Sonia. So what's the predisposition here? Well, it's that childhood trauma, isn't it? So that has increased her risk. We know that is a part of the diathesis-stress model in the modern sense. And she's also got a family history of schizophrenia there, because the dad has schizophrenia. So she's also got possibly a genetic predisposition as well. So certainly a higher than average risk for schizophrenia, okay? So there's your application with your knowledge. Now let's tackle the last part of the STEM. We're talking about medication and therapy. That sounds like combination treatment, which is the interactionist approach to treating schizophrenia. So we're going to describe what that means. We did that a minute ago in the 2 marker. And then we're going to make some links. So she's already on medication, and adding the therapy might reflect an interactionist approach to treating schizophrenia, because maybe the medication would help her to engage with the therapist, whether that's CBT or family therapy. And the therapist can maybe, improve the situation in terms of trust and explaining what the medication is for, and improving compliance, or Sonia's compliance with that drug. Okay, so it's all working together. Okay, there you go, knowledge and application. Okay, we've got an 8 marker here, outline and evaluate the interactionist approach. Okay, so this is very, very similar to the 16 marker that's next. The difference being, this is just about the explanation, look, and the 16 marker covers treatments, okay? So I'll go through the 8 marker, and then I probably won't really add much for the 16 marker. We'll just talk about the treatment side of it, okay? So for this one, knowledge of the interactionist approach. Again, we've said it a few times already. Talk through the diathesis-stress model, what that means. Make sure you're taking the more modern approach to it. So you're talking about the diathesis, as in the predisposition, not just being a gene. It's polygenic, we know now. So there are lots of different causes, and it could be lots of different candidate genes involved in schizophrenia. But also, it doesn't actually have to be biological. We understand nowadays that the origin of schizophrenia could actually be in things like childhood trauma or abuse, okay, like we mentioned with Sonia a minute ago. So that would be your knowledge of the diathesis bit. And the stress is about a trigger, so it could be about a stressful life event. It could be about substance abuse as well, okay? And I know some of the evidence or some of the books talk about the role of maybe living in an urban environment as well. So you could put that in as an example of the stress. Now, to really max out some marks here, what I'd be throwing in there to really convince the examiner that I'm level 4 and I know my stuff, I'd be using words like additivity, yeah? So if you haven't come across that before, it's the idea that the diathesis and the stress adds together, and each of the additional kind of risk factors and the additional triggers are adding on top of that. It's a bit like, a bucket filling up. It all adds up over time, and then when the bucket overflows, that's when we start to see schizophrenia, okay? So additivity, it's all adding up, okay? So that's my knowledge. In terms of evaluation for an 8 marker, probably looking at 2 evaluation points personally. So you could talk about maybe a strength is research support. So you could talk about things like adoption studies or twin studies. You might be aware of, or you're probably aware of the adoption study by Tianari et al. And the fact that, the kids that went on to develop schizophrenia were largely the ones that were in the high stress family environment or the dysfunctional family environment, but also had that genetic risk because their biological mother had schizophrenia. So that's research support. You could take that a bit further and discuss issues with that study. The fact maybe that, it doesn't account for the fact that we now understand that the diathesis doesn't have to be genetic. You could talk about the fact that a lot of it was kind of based on observations and, the family behaviour when they were rated as dysfunctional. Maybe you've got demand characteristics and all of that going on. I wouldn't go too far in that direction. The point is maybe the research isn't perfect, and link it back to the question, if the research isn't perfect, that undermines the support provided for the interactionist approach to schizophrenia. Okay, so that could be a discussion paragraph. And then you might talk about a limitation. You might say that because of this issue of additivity, it makes it very difficult to actually pinpoint the true origin or the true point at which a person had their schizophrenia triggered. Now, what I mean is, if you've got 5 or 6 different stresses that are building up between the ages of, let's say, 12 and 25, you've got, loads of different triggers. Has any of them actually caused schizophrenia? What is it that actually triggered it? Obviously, it's a combination of all of it, but my point is what we can't do is pinpoint what has actually caused schizophrenia. Yeah, there are difficulties in determining the cause, which you might argue is maybe a validity issue or an issue about how useful the approach is. Okay, you're just kind of saying, oh well, loads of things cause schizophrenia, it all adds up. Yeah, which is fine from we know what we have an explanation for schizophrenia, but if you're just saying everything causes it and it all adds up, it's not necessarily the most useful explanation, is it? All right, so that's how I might tackle an 8 marker. Let's move into the 16 marker. So same thing for the explanation half of it, and then I would then do maybe a little knowledge paragraph on the treatment, and maybe it could be a single discussion paragraph on the treatment. It doesn't have to be perfectly balanced, but there should be decent coverage of both sides. So treatments we've already talked about. It's about combination therapy and the fact that you are talking about maybe antipsychotics plus CBT or family therapy added on, and you're talking about how they work together. Yeah. So that's the knowledge, and then for the evaluation of that, you could do 1 or 2 paragraphs, depending on what you've done for the explanation half of this essay. And you might be aware of some research support for combination therapy. You might be aware of the study by Nicholas Tarrier, or even the later one by Guo et al. It doesn't really matter. I'm going to go with the Tarrier one. So the Tarrier study compared combination therapy groups with single therapy groups. I think they were just on antipsychotic drugs. And after, I think this might have been an 18-month study, could have been 12. Doesn't really matter for the purposes of this. But at the end of the study, the combination groups, they showed lower levels of symptoms than the single treatment groups, which supports the role of a combination approach or an interactionist approach to treating schizophrenia. Okay, so that's a good strength. You could then take that a bit further, and you could discuss that actually maybe we need to look at maybe the longer term impact, because if you're only looking at it over 12 months or 18 months, it doesn't really tell you about, as I said, the long-term effect of combination therapy. You could, if you know some more specifics about that study, I know with the Tarrier one, even though there was a difference in symptom levels, they also measured hospital readmissions, and there was actually no difference in hospital readmissions between the combination groups and the single treatment groups. So you could say, yes, okay, maybe it's improved their quality of life because the symptoms are a bit lower or less severe, but the same number of patients have actually ended up in hospital nonetheless. So was it useful? Was it worth doing? So that's maybe a two-sided discussion you could have about treatments. If you wanted another point, you could go down the practical or the economic side of it, and you could talk about, CBT and family therapy are already quite expensive, especially in the short term. Drugs over the long term become quite expensive. So if you're doing both, it's obviously the most expensive way to treat schizophrenia. So that could be a limitation, but you could then develop that and discuss that with the idea of, yes, okay, it's the most expensive, but it's also the most effective. And even if we have, a year of therapy and then 10 years of antipsychotics or whatever, in the long run, if it is, 5 or 10% more effective than standard therapy, are we going to actually be saving the NHS money later down the line? So there you go. There's plenty that you can discuss there. Possibly, I don't know if they'd ever do this or not, of course, but you might get maybe a 4, 6, even an 8 marker just on treatments from an interactionist point of view. So I think it's worth just being aware of maybe 3 marks of knowledge for the treatment, or certainly 2 or 3 marks, and then probably 2 discussion points just on treatments. Okay, and look out in the exam. Look out for, is it saying just the interactionist approach, in which case you can maybe do a bit of both, or is it actually saying interactionist explanation or interactionist treatment? All right, so yeah, look out for that. Okay, how did that go for you? Why did that happen? So why did you do really well on that? Think about that. Maybe try and replicate that. Why didn't you do well? That's fine. What are you going to do about it? Yeah? Or what do you not need to do now? You know, if you've smashed something, fine, trust yourself on that. Spend your time on things that you need to. Right, that was me discussing the interactionist approach to explaining and treating schizophrenia. I hope that was helpful for you guys. I hope you got on well with it. Let me know if you've got any comments or questions down below. See you in another video. Bish bash bosh.